life-changing breast cancer trials. And it's a pleasure to welcome and invite Dr. Amit Bhargav, sir, a Senior Director, Medical Oncology at the prestigious Fortis Hospital, Vasant Kunj. With this note, sir, it's a pleasure to invite you to start the proceedings. Over to you, Dr. Amit Bhargav, sir, for your kind words.
Thank you, Tarunji, and I welcome all of you, and I really appreciate all my faculty members to have agreed for this meeting on a very short notice. Uh, this time when we reviewed the SABCS, data, we found a lot of articles in this meeting which were actually challenging and which could be a game changer even today or in future. So we picked up a few very selected abstracts and we thought we would discuss it on a panel. So without wasting much time on this, I would invite Dr. Nidhi Bhargava to open up the session for her first presentation, which is evaluating image-guided optimization of neoadjuvant chemotherapy duration in stage 2 and 3 HER2-positive breast cancer. Dr. Nidhi Bhargava is a consultant radiologist and Dr. Nidhi, over to you.
Dr. Nidhi, ma'am, your phone is muted and the presentation, if you can start the presentation, please.
Nidhi, you are muted. You need to unmute.
I think she needs to rejoin because her video was also stopped.
Yeah, we are requesting ma'am to rejoin. So yeah.
Yeah. Well, if she's having any issues, can we proceed with the next?
We'll wait for a minute, sir. Just wait for a minute.
Sure.
I think ma'am is just joined. Just wait for a minute. Yeah. Yeah, ma'am has joined. Hello, ma'am. Can you hear us properly, Dr.
Yeah,
Nidhi,
I
ma'am?
can. Yeah, I
Yes.
can.
So the
Yeah.
slides are with you. Yeah, over to you, please. Yeah.
Yeah. Good evening, everybody. It is a very interesting thing that I'm going to be talking today. I'll just present the radiological part of it. This is image guided or MR guided optimization of the neoadjuvant chemotherapy duration and protocol. Can I have the next slide, please? So this protocol, which has been devised, this is talking about early complete responses after only 3 cycles are very common. Secondly, monitoring treatment response with MRI breast may help to identify early complete responders. Next slide. Now, in this study, what was put in was that after every 3 cycles, we did a multi-parametric breast MR scanning. This was a TIVA weighted sequential dynamic scanning, and they looked in for the radiological complete remission. Radiological complete remission they defined as absence of pathological enhancement in the original tumor region by the breast MR, or a negative FNAC or a core biopsy or a vacuum assisted biopsy of the marked lymph node in the cases of lymph node positive diseases. This was more important for the hormone response positive patients. This we will come to later why so. The second point was that even minimal enhancement in the original tumor bed, which was similar or less than the surrounding area or the contralateral breast tissue, was considered physiological. So they talked about the contrast enhancement, the qualitative and the quantitative analysis of it. Based on that, they talked about radiological complete remission. That was compared with the pathological complete remission to talk about as to how to further proceed about the neoadjuvant chemotherapy or surgery or both or the further protocol. Then small foci of enhancement in the original tumor bed. They did not qualify as radiological complete remission. So even if the small foci were present, then this was not marked as radiological complete remission. Complete resolution of the mass was not required to label at radiological complete resolution. So it was primarily the pattern of contrast enhancement which made the decision about the complete remission. The technique that they used was T1-weighted dynamic sequential scanning at 1 millimeter and for at least 7 minutes. Then locally trained radiologists were used, specific radiology reporting protocols, which talked about the qualitative and quantitative contrast enhancement pattern. Those who showed MR MR positive lymph nodes, for them either 18 gauge core biopsy done, 2 attempts, or in May 2022, they incorporated the vacuum assisted core biopsy. This was again done for hormone positive patients, wherein to confirm a comparison between the radiological and the pathological response. 9 to 12 core biopsies were done to be sure about the course of neoadjuvant chemotherapy. Radiological complete response or remission was assessed at 3, 6, or 9 week cycle, which was the maximum. Next slide, please. Next. Then we talked about the results. In the results, 169 patients who were hormone receptor negative were the people who attained radiological complete remission. Out of those, 147 had a pathological complete remission. This was approximately 87%. Then when we talk about the early responders or the early radiological complete remission patients, there were 84 patients, out of it 74 also showed pathological complete remission. So that is 88%. So 87 to 88% of the patients with hormone receptor negative HER2 new positive CA breasts showed a complete radiological remission in MRI and also showed a complete pathological remission. On the contrary, when we look at the hormone receptive positive patients, 138 of those showed a complete radiological remission after 9 cycles, and out of which only 73 patients had a complete pathological remission. So that is 53%. The early responders, there were only 68 of such patients, and out of which 34 of them showed a pathological complete remission. So this is approximately 50 to 53%. So for these patients who were hormone receptive positive, I feel better monitoring tools are required, which could be either a better volume data acquisition with optimized scan timing or an accurate predictive biomarkers are what are required. Next slide, please. Next. 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 Yeah. So in summary or to conclude is that in 1 or 3 patients with hormone receptor negative, HER2 positive, and 1 in 6 with HER2 positive, with hormone receptor positive, HER2 positive breast cancer achieve a pathological complete remission with only 3 cycles of neoadjuvant. These patients have an excellent 3-year event-free and overall survival. Pathological complete remission can be identified reliably with the contrast enhanced MRI for hormone receptor negative tumors. Better monitoring tools are needed for hormone receptor positive tumors. This therapeutic approach offers a significant reduction in toxicity. Thank you.
Thank you, Dr. Nidhi. I think so we'll keep the question answer sessions at the end. So we go over to the next presentation. I'll invite Dr. Vedant Kabra. Dr. Vedant Kabra is the Principal Director of Surgical Oncology at Fortis Memorial Hospital. and he's been my fellow colleague from Tata Memorial Hospital. So, Dr. Vedant, over to you. And he would be talking on no axillary surgery versus axillary sentinel lymph node biopsy in patients with early invasive breast cancer and breast conserving surgery. A final primary results or analysis of the NCMA trial. Dr. Vedant.
Yeah, thank you, Dr. Amit, for involving me in this meeting full of medical oncologists. You've kept radiology as well as a surgical topic. So, okay. Can you see my screen?
Yes, sir.
Yeah. Okay. So we know that sentinel node is a very reliable means to avoid axillary node dissection and its morbidity in form of lymphedema and arm and shoulder morbidity. And we have also seen various trials now which say that even if SLNB is positive in selected patients, we don't need to move ahead with ALND or complete axillary node dissection. Now, going ahead, Society of Surgical Oncology from US, in their choosing wisely statement in 2022, they said any lady who is 70 years or more with a T1C N0 hormone positive HER2 negative tumor does not really need any axillary surgery. So no SLNB, but this is not applicable to everybody. So what we are trying to answer through these trials is axillary surgical staging needed in clinically N0 axilla? And can imaging replace surgery for a reliable axillary staging? So there are various trials going on. Two of them actually have reported their results. The Sound, which is from Milan Group, reported that it is non-inferior if you omit SLNB in tumors which are less than or up to 2 centimeters. In SEMA intergroup is the study which I am going to review today. Then there is a Dutch trial and there is a Korean trial, and results are expected in next 1 to 3 years from these trials. So in SEMA is an intergroup Sentinel MAMA trial, which is a multicentric non-inferiority trial, 142 sites in Germany and 9 in Austria. And they have taken 18 years and above patients who are T1 and T2. So remember, Sound trial was only T1. This is T1 and T2. N0 clinically as well as by imaging. And imaging was mostly in more than 94%, it was ultrasound. There was a 1:4 randomization, 1 for no staging and 4 for SLNB, which is the standard of care currently. And they also randomized second time, which the results have not yet been presented, which is if the sentinel node were positive, 1 to 3 nodes were positive, they did a second randomization whether to proceed with axillary node dissection or just to observe. But results are awaited for that randomization. So locally, if they found any node which is suspicious on imaging, they did either FNAC or core biopsy. And if it was negative, then they could be included in the trial. They did breast conservation surgery of the same side with whole breast RT and boost for the same side. Axilla was specifically not targeted, and you all would remember Z11, where high tangents were going to axilla, so it was criticized. And APBI was not allowed in this trial. Also, to have good quality review from each center, they had a central review of the RT planning for first 3 cases. And once they were confident that those are being planned nicely, they stopped reviewing them. And the primary outcome was invasive disease-free survival, which would include local recurrence, regional recurrence, distant recurrence, death from any cause, contralateral invasive breast cancer, or any kind of invasive cancer, non-breast invasive cancer as well. And secondary outcomes were overall survival, loco-regional disease-free survival, distant disease-free survival, quality of life measures, and RT dose in the various axillary levels. How much of RT is going in various axillary levels. They also assessed quality of life through the EORTC scales. 2 of the scales were used. Sample size calculation depended on a presumption that 5-year IDFS would be 88%, and the upper end of the 95% confidence interval of hazard ratio should be less than 1.271. Only then it will be considered as significant. They expected 851 primary outcome events, and intention to treat the size was 5230. They added 5% more because they were expecting some exclusions to happen. So the target sample size was 5502 patients. They also planned that if 851 events do not happen, then we will do a time-driven analysis, which will be done when minimum follow-up will cross 5.5 years. So the last patient will be followed up for at least 5.5 years, and then they can do the analysis. That's the consort flow diagram, where intention to treat there were 5,154 patients, and per protocol were 4,858, and which is the result which is mainly reported, the per protocol. Statistical analysis used Kaplan-Meier product limit method and Cox proportional hazards methods. They did Pocock-Simon minimization method so that the variation between the two groups is minimized. This trial was run between 2015 to April 19. Baseline characteristics were well matched. The median age was 62 and only 10.8% were below 50 years of age. So you can see largely older population. Median tumor size was 15 mm by palpation, but only 11 mm by imaging, which was 95% USG. T1 tumors were 91% by clinical method, but pathologically 80% were T1. So subgroup of T2 also, the median size was only 25 mm. So you can imagine all the tumors were very small. And 15% of these patients had sentinel lymph node positive. It was around 13% in the sound trial. Baseline characteristics in per protocol set is similar, and 95% were HER2 negative, HR positive, that is hormone positive subtype, which is luminal A, and a very good subgroup. Sorry. The median follow-up was 73.6 months at the time of this report, and IDFS per protocol did not show any difference. It was 91.9% in no sentinel node biopsy group and 91.7% in the sentinel node biopsy group. And you can see the hazard ratio is 0.91. It is not crossing their limit of 1.2. So the upper limit is 1.14. Primary endpoints included these various factors. Most of them are same, but you notice that axillary recurrence expectedly was high in the no SLNB arm. It was almost more than 3 times the SLNB arm. The overall survival also was no different. And when it was, so far what I showed was per protocol analysis. Even with intention to treat analysis, the IDFS, the invasive disease-free survival, remained the same. Surgical complications or quality of life, it was seen that lymphedema, shoulder and arm mobility restriction, as well as painful movement were all less in the no SLNB arm, although the difference is not really very great, but still there is a difference between the two sides. So the discussion points are, although there was a 15% nodal involvement in the SLNB group, still the cumulative axillary recurrence in the no surgery arm is only 1% at 5 years. So that means a good number of those patients are taken care of by other adjuvant therapies, especially systemic therapy. The previous trials have shown that ALND does not improve outcomes. And now, with last decade or so, there is an increasing reliance on biology rather than the anatomy for deciding the therapy. So this may not be really required that we always do axillary staging. However, in younger patients, nodal status may become significant because we know that R responder did not rule out chemo advantage in lower intermediate risk scores. Also, if you want to give extended hormone therapy or ovarian function suppression, you need higher nodal burden to be there, and you need nodal status to be known to you. Not only for systemic therapy, but also for radiation. If there is a positive sentinel node only, then RT can be escalated to include the axillary region if surgery is not done, which we know from Amaros trial and then a couple of other trials. And on the other hand, if the patient is above 65 years, some of the patients, if they are node negative, no radiation is needed, even if breast conservation has been done. Or in some patients, only breast APBI can be done. So there is a de-escalation of radiation. And these things cannot be done unless we know the nodal status, which cannot be known if we don't do axillary surgery. Now the question is, how reliable is ultrasound to detect the nodal involvement? There was a meta-analysis published in 21. The sensitivity ranged from 24 to 94%. So you can imagine the wide variation. But in the current study and also in the sound study, ultrasound was found to be clinically meaningful. Why? Because only 15% had metastasis, so 85% sensitivity. The extensive nodal involvement, which we call as 4 or more nodes, was found only in 0.2% of these 15%. And the cumulative axillary recurrence was very low at 1%. And similar studies, in fact, these statistics were even better with sound trial. So if we compare with the sound trial, INSEMA used T1, T2 patients and sound included only T1 patients. In spite of this difference, the median tumor size in both the trials is 11 mm. So whatever INSEMA has included T2, they were very small T2s probably. Primary outcome was invasive disease-free survival in INSEMA and only distant disease-free survival in sound trial. And that is why, because it is a broader primary outcome, they had higher events in INSEMA. The intrinsic subtype and the median follow-up is comparable. We know that the more low risk group or luminal A group was present in both the trials. Also, in view of the APT trial results now, in a small HER2 positive tumor, nodal status again becomes important for de-escalation of systemic therapy. So here is another example where we would need to stage axilla. So these are the questions that we will need to answer. Now, there are certain limitations that authors have accepted, and they said that the significance of reported results is restricted to low risk patients because only 20% were T2, and of which the median size was 25 mm only, and total median size was 11 mm. And only 3.6% patients were grade 3 of all the patients. Now, they also had assumed 5-year survival of 88% on the basis of which sample size was calculated. But it is actually less than the actual trial rate, which is 91.7 and 91.9%. So the basis was a little different and it may also skew the results a bit. Median follow-up of 76 months is good to report a 5-year result, but we know that in luminal A we can miss late recurrences and we definitely need a longer follow-up to have a more robust data from this study. So authors conclude that INSEMA trial with more than 5,000 patients has shown non-inferiority of omitting SLNB in early breast cancer, clinically N0 patients who are undergoing breast cancer surgery, breast conservation surgery, and have a non-inferiority margin of 1.271 or less. They showed that the overall survival at 5 years was 96.9 versus 98.2% with or without SLNB. And they have suggested that we can omit SLNB in suitable patients who are aged 50 years or above with T1 disease, N0 disease, grade 1 and 2, hormone positive, HER2 negative breast cancer. So very select group of patients. And this is the group which actually formed the majority in their trial as well. So my take on INSEMA trial is that it is a very well conducted multicentric RCT with recruitment reaching their level, although the per protocol analysis was on a much lesser number of patients. However, it is on a select low risk patient group who are undergoing breast conservation. So mastectomy was not included. It is a per protocol analysis, but results are compelling and they were similar in intention to treat analysis as well. Now, results from other ongoing trials are likely to strengthen these conclusions and probably expand the indications of omitting sentinel node biopsy because right now we have a very small group of patients where we can exclude it. Now, in Indian context, I'm happy that Dr. Nidhi is also here. The problem is of how reliable is a run-of-the-mill USG done across the country. So we need to have good radiologists who are doing good ultrasound. The other problem is our tumor size. Our tumor sizes usually are much higher as compared to the the report that is reported in trial. INSEMA has shown better quality of life, although the difference was very small. But ideally, quality of life should be the primary endpoint rather than the secondary endpoint for it to be more robust. And it is applicable, as I have said earlier, also to a very select group of patients. And probably, if we have a reliable ultrasound and we have these criteria of the patients met, that is T1, N0, HER2 negative, hormone positive, low grade, and postmenopausal who are undergoing BCS, we can think of omitting SLNB in those patients. Long-term follow-up is needed in this low-risk patient because late recurrences will tell us whether omitting is okay or not. Thank you very much.
Thank you, Dr. Vedant. A very interesting, game changer, which we can expect in future. So we
Yeah.
have time for one question. Any one has a question, or I have a question for Dr. Vedant. Anyone for any questions? No. So, Dr. Vedant, one question, which after going through your presentation, I mean, in your clinical practice, how comfortable would you be, omitting a sentinel node in the said group which you mentioned? So, is it actually feasible in a private setup like what we all are in?
So
Would you
now
be
we have
comfortable doing it right now, or
now
you
we
would
have
like to wait for that?
Yeah, good question, and that's actually the question that we need to answer. But with two good trials now, especially this one, which is above upwards of 5,000 patients, I think we should be reasonably confident in trying to omit, at least in older patients, maybe not 50 plus, but 60 plus. We should be starting to omit it if we are okay with the sonologist who has done the ultrasound. That's very important. Unless you are confident about your sonologist, you should not do it. The second thing is we can also do for next maybe 15, 20 patients, 30 patients, we see the sensitivity of our sonology, or we can retrospectively see the sensitivity of our ultrasound reporting and then start practicing this. So in with these caveats, I think we can definitely offer it to select patients. So private practice should not be a deterrent because we have good data available for those select patients and we can practice it. However,
Thank
SLNB
you.
is a small procedure with really very low morbidity. If you see, the lymphedema rates were not more than 5%, 6%. And even shoulder movement was just
Correct.
2%, 1 to 2% difference between the no surgery and auxiliary surgery. So it's not such a big deal, very honestly.
You know what? There is a said population which is even bothered by that 1 to 2% restriction of movement.
Agreed, agreed.
So,
And
so
it
we need
happens. It
to.
happens more in obese patients where we have to dig
Right.
much deeper into the axilla to find those nodes.
Thank you, Dr. Vedant.
Thank you.
We move on further, and now we have a topic which is the burning thing in medical oncology these days. So I would invite Dr. Gurudat Gupta. He's a senior consultant and head histopathology at RGCI, and he's talking on genomics, and the topic is from potential to practice, realizing the clinical utility of circulating DNA, tumor DNA. So that's a very interesting topic, and Dr. Gurudat, welcome on this forum, and the forum is all yours.
Thank you, Doctor. Should I share or should I share the screen or will show the
Yes, sir,
slide?
you can share your slides.
Because it is actually PDF now. So I'll try. And see the slides. Okay. So this is the presentation done by Dr. David Skascon in the SABCS 2024. So the topic is from potential to practice realizing the clinical utility of ctDNA, that is circulating tumor DNA. Now, the Dr. David has described two trials, one positive, one negative, as a where the retrospective utility of ctDNA is highlighted, and then he takes the prospective trials and with in early breast cancer and in advanced breast cancer. So we'll go through them. And one thing in this presentation, the use of ctDNA test, which has been used, is actually tumor-informed ctDNA. What we usually practice or we perform in our labs is a plasma only, tumor uninformed ctDNA. So in this case, first the tumor, the somatic tumor, it is by NGS, the whole exome sequencing is done. The mutations are identified, and those mutations are then detected or used for detecting the ctDNA and MRD, basically molecular residual disease. So this is the basis for this presentation. Actually, I can't move it because this is a PDF. I think you will have to share.
No issue, sir. I will share.
The team can share Dr. Gurda's slides. Tarunji, can you please ask someone to help?
Sir, can I run from my side?
Yes, yes, please.
Yeah, sure, please.
Yes. Thank you. Yeah, no, the second slide or one slide before this. Yeah, this one. So he first describes the clinical utility. What is the clinical utility? The clinical utility is basically defined as the likelihood that a test will, by promoting an intervention, result in a improved health outcome. So it is about the predictive biomarker. In this study, this case, it is the ctDNA, which can lead to treatment optimization, and another use is recurrence interception. So recurrence interception is basically detecting the tumor before it is clinically evident or metastatic. So this is the recurrence interception, and there's a role for ctDNA in this uh, scenario. Next slide, please. So first trial, which is a negative study, that is IMvigor 010, which was for urothelial carcinoma, muscle invasive urothelial carcinoma high risk, and the endpoint was not reached in this trial, and it was a negative trial. Next, please. Now, what they did was they did a retrospective correlative studies to identify a predictive biomarker. So in this case, the ctDNA negative and ctDNA positive cases were then studied, and what they showed was in the cases where ctDNA was positive, then the atezolizumab actually improved the survival. So that was the outcome of this retrospective analysis. Next, please. Now, second trial, Monarch E. This was a positive trial, and in this they also did a retrospective correlative analysis, and in cases where the ctDNA data was available, which was only 25% of the patients which were in the trial, and they showed that this where the baseline was negative, their ctDNA was negative, the outcome was good, and the p-value was significant. So you can see in this, the yellow, the blue one are the ctDNA negative, and red is the ctDNA positive. However, this was limited because this is a retrospective finding, and ctDNA subset which was enriched in this particular subset was the patient with uh, invasive disease-free survival events within 24 months. So this was not very reflective of the whole overall population of the trial, that is monarchy. Next, please. So this is the retrospective analysis of early breast cancer trials, and they may apply both to positive and negative trials, but the limitation will be that negative trial intervention may benefit no one, and baseline testing may fall short as qualitative predictive biomarker. So because this is a longitudinal, the ctDNA will keep on changing during the course of treatment. So it has to be checked regularly, say 3 monthly or 6 monthly or yearly. And assay is very critical. So inadequate sensitive or specificity will misclassify. and excludes those who are initially ctDNA negative. So if person is ctDNA negative, then usually it won't be subjected to an intervention. Next, please. So ctDNA may help in avoiding unnecessary treatment while preserving good outcomes. So that was shown in IM Vigor, where the atezolizumab did not improve the outcome where the ctDNA was positive. So this is the thing. So no prospective trial data to support the clinical utility. So now what is needed is actually, this is an ongoing area of investigation. And next he discusses a lot of prospective trials which are going on. Next, please. So a ctDNA informed de-escalation strategy he first described. Once a study is safe DE de-escalation, where primary HER2 positive or TNBC with high TILs, clinical stage 1 cases were included. So such cases were identified, followed by surgery. If they were not stage 1, they were excluded. Then ctDNA was done. If they were negative, then they were put on surveillance after completion of local therapy, and no adjuvant chemotherapy was given. Then they were kept on CT surveillance. If they became positive, then it was decided whether to give adjuvant chemo plus or minus HER2 targeting. Then if they are positive, then adjuvant chemo and targeting. Now this is an ongoing study, and still we don't know whether this can be used routinely until I think in 2027 the results will come. Next, please. Now, second thing he says is about the recurrence interception, the role of ctDNA as a MRD. So initially, the maximum standard therapy can be given. Then the ctDNA can be done, normal DNA and tumor DNA. If there is undetectable ctDNA, observation can be done. If there is detected DNA, then randomization, some to observation, some to therapy, and then check for the clearance of ctDNA. Now, the question is who to give the therapy, how to do it, how often it should be done, and what is the meaning of MRD, because there will be a lead time. Because in all these studies, it shows there is a lead time of, say, a few months or a few years. And what about the subclinical metastasis? What is the potential for cure? Next, please. So these are the various studies which are there for early breast cancer, for TNBC, ER, hormone positive, and HER2 positive. And one such study survived, which includes all this TNBC, estrogen, and HER2 positive cases, and it is ongoing. Now, one thing I would like to highlight here is this Signatera is the most common ctDNA testing done in most of the these trials. And in this, as I already said, this is a tumor-informed ctDNA. It is not the routine ctDNA plasma, if only ctDNA. So that we should keep in mind. These two were actually not used. Challenges and opportunity for breast cancer interception. So we have already said what is interception. So MRD is a moving target, and we can see detect the subclinical metastatic disease, but when we detect it, maybe it is too late to cure. And second problem in our setting, especially in low-income countries, how to manage screen to treat ratio, because you will have to screen thousands of patients to treat few. So it can be hardly 7% or 10%. And it requires active and appropriate treatment option. If there are no such options, then ctDNA is of no use naturally. And impact of MRD positive diagnosis, let's say if you are in a study and there is MRD positive, then if you randomize patient to observation and you know that treatment might improve, then there is the issue. And it avoids unnecessary over-treatment, enable shorter, more efficient trials, and use surrogate markers to triage patient therapies. Next, please. So this was early breast cancer. Now coming to advanced disease. So genotyping can be used when the patient fails, leading to risk stratification, and according to that, treatment modification can be done. Next, please. So this is one example. This is a patient progressing on CDK inhibitor plus AI. That is aromatase inhibitor. So here is the ESR1. There is detection of low levels of ESR1 mutation. So uh, can we give the specific therapy for this patient? That is the question. So it is ticked. So yes, we can do that. Then detection of P10, which is a tumor suppressor, RB1. So if the fraction changes, does it have a prognostic implication? This is guarded yes. Then could identify molecular progression and intervening early has improved her outcome? That we don't know. With the presence of, say, another tumor suppressor, RB1. Next, please. So identifying and treating the molecular progression, one such trial is PADA1. And in this, the strategy was to target the rising ESR1 mutation and when they become detectable under the AI and PAL treatment. So this was the trial. And in this, once the rising ESR1 mutation was detected, the patient was randomized and the AI was changed to fulvestrant, and then there was an option for after the step 2, option for crossover for all the patient to crossover to fulvestrant. Next, please. And in this case, ddPCR was used for ctDNA. So this is the survival from the randomization, and this is the survival 2 from randomization. This is 33 months and this is 24 months. Next, please. Now, this is the Serena 6, in which the same strategy was used. However, population was slightly different and tests used were different. It was not ddPCR, it was Garden 360 CDX. In PADA1, only 4 ESR hotspot mutations were checked. In this, 11 were checked. It has different LOD and SERD use was different. However, partner CDK can be same. Next, please. So to summarize, this circulating tumor DNA detecting technologies are rapidly evolving, and this is emphasized that clinical availability is not same as clinical utility. So everywhere ctDNA might not be informing the treatment. Test population, intervention, and outcomes are critical variables in study design, as we have seen. Rigorous trial supports by high-quality data are essential, and iterative development will be necessary. So whatever the information is gained from the trials, that will finally optimize the utility of ctDNA in clinical practice. Thank you.
Thank you, Dr. Gurudat. Really very nice presentation and quite informative. So any questions for Dr. Gurudat? Dr. Gurudat, I have one for you.
Yeah.
You mentioned that there are various techniques for evaluating the ctDNA, and the systems are evolving. So as of now, which one do you feel one should go for evaluation for ctDNA? Because a lot of companies, a lot of panels are available. So should you go in for a company or should you go for the technique which they are by which they are doing a ctDNA?
I think the main thing is it should be a standardized test, validated standardized test. Problem is, as I said it at onset, that all these trials, if you see, they have used tumor-informed ctDNA.
Okay.
So what is available at present in our country, what we are doing is, we are doing plasma only ctDNA.
Plasma
Say for
only
lung
CT.
cancer, it is commonly done because there are,
Right.
you know, the mutations, EGFR mutations or any other mutations that is already tested on your tumor. And then you can detect it on your liquid biopsy. However, in breast cancer, say, you require a larger panel. And if you go for NGS or any other technique on this liquid, then it might not be, it might not have the same depth to detect the very small fraction. As was shown in that example, the fraction was very small. If you have noticed that, it was hardly 0.26.
Right. Right.
So you require that kind of sensitivity. And Signatera, what I mentioned, it does 1 lakh depth. So routinely what is
Right.
done is 30,000, 40,000. So
So
that
depth
much
is very
data,
big.
that much expensive test is not very easy to have in a resource poor.
Anyways, this is an evolving field, and we have so much to learn from this now. I
Yeah.
still feel that I'm back to my school days of learning when this whole thing came up. So thank you, Dr. Gurudat.
Thank you.
Just one question, Dr. Amit. I
Yeah,
want to
Dr.
ask
Mohit.
one question to Dr. Gurudat. Yeah.
Yeah, please.
Yeah. So, Dr. Guru, nice to see you after such a long time.
Yeah.
Just one question, like in Signatera for an early, yeah. Just for Signatera and early breast cancer, you require a tumor mutation prior. So you
First,
need a sample prior to get a residual disease. So how long? So supposedly a patient has undergone a surgery. Now 2 months later, you want to get a Signatera. Can you get the kit made from the prior tissue which was operated?
yes, it is made from the tumor tissue only. First, you do whole exome sequencing, identify the SNVs, that is the mutations. Then you design, they take 16 mutations, and then they do the ctDNA.
So how long, for how long, when can we do it? So supposedly someone wants to do it an year down the line, the patient was operated. Is Signatera possible in that situation?
See, what I saw in all these trials, it is usually when the patient do not have any relapse on the treatment, then this test, I mean, ctDNA is used as a serial testing for detecting any MRD, say molecular residual disease. If at baseline you have disease, then maybe you will go for upfront treatment itself.
Right.
I think it is more for early breast disease, and I think early relapse, if
No,
possible. That is
see,
the
what I
thing.
wanted to ask was sometimes what happens is that 6 months down the line in a HER2 positive breast cancer, early breast cancer, patient wants to stop the therapy. They have some concerns regarding coming repeatedly to the hospital, cost and something or the other, whatever may be the reason. At that point of time, can we order a Signatera at that point of time to be see the mutation in the early tissue which was operated and then make a kit out of it? Is it possible?
I think this SAFE D is one such trial where HER2 and TNBC were, I think, included. So in those cases, only stage 1 disease was studied, where there is no metastasis or any other risk factor. Then it was used
I guess,
as
Mohit, there is no data on this, what you said.
whether to
There's
treat or
no
not,
data on what, also fix.
to de-escalate basically. But there is no, I
Yeah.
mean, there's no prospective trial data to support that whether you
On this.
should give or you should not give. That is the problem.
Right.
Should not get.
So if the patient is free of disease after 6 months, then you can go for it, I think. No issues.
Okay. Right.
Thank you, Dr. Gurudat. And now we move further. I would invite Dr. Mohit Agarwal, who's a Senior Director, Medical Oncology at Fortis Hospital, Shalimar Bagh. And one request before I give him the topic is just to restrict to medical oncology only. and not deviate to stock market. So we'd be talking on residual invasive disease in HER2 positive early breast cancer, the Catherine data update. So over to you, Dr. Mohit.
Okay, thank you, Dr. Amit. And I must say that seeing you after a long time, your present attire and your hairstyle makes you look like a judge, a Supreme Court judge at the moment. Okay, however, jokes apart, I'm actually traveling, so I'm in a poor network area. So bear with me if there's some crackling of the voice. Okay, so the topic which has been ascertained to me is phase 3 study of adjuvant Kadcyla versus trastuzumab for residual invasive HER2 positive early breast cancer after NACT and HER2 directed therapy. And this is the final IDFS and updated OS analysis of the CAT3 trial. And as a standard disclaimer, these slides have been provided by Roche. Next slide. So we just to get the things into perspective, the Catherine study design, we all know prior neoadjuvant therapy, which would say 6 cycles of chemotherapy and 9 weeks of trastuzumab, and a second HER2 targeted therapy in the form of pertuzumab was allowed. And what we tested for is something like a residual invasive tumor in breast or axillary lymph nodes, and there was something like a randomization within 12 weeks of surgery. The randomization was 1:1, either to Kadcyla or to trastuzumab in patients who were having a residual disease. So if you see the initial curves of these trials, you would see that patients who were achieving something like a pathological CR were achieving something like a straight line and were achieving a very good IDFS, while the graph was dipping down in patients who had a residual disease. So something had to be done to cover that gap, and Catherine tried to cover that gap by doing so. And radiation and endocrine therapy were allowed as per the protocol, and switch to trastuzumab permitted if Kadcyla was discontinued. The primary endpoint here was IDFS, and the secondary endpoints were DFS, OS, and DRFI and safety. So next slide. Next slide. Yeah. So this is the primary analysis, and this was presented in 2018. Sorry, please, the prior slide. Yeah. So this was the primary analysis which was presented in 2018. We showed that Kadcyla, when given, improved the 3-year IDFS in patients with residual disease as compared to trastuzumab to a tune of 10%. We saw at that moment of time that the OS graphs were tending to separate, but the data was immature. So it was not really very significant, but the hazard ratio was still 0.7. Next slide. Okay. Now, what were the analysis milestones? So we had a first interim analysis in 2018, subsequently a second interim analysis at 2023, and then a final analysis 12 years after this randomization and the data. And this was event driven after approximately 384 events have been recorded, and there were about 385 patients with an event. So, and with second OS, it was all pre-planned. And during the follow-up period, that is 30 days after the last dose of study drug, only death, serious adverse events, or other adverse events of concerns that are believed to be related to prior treatment with study drug or drug study procedures were reported. Next slide. So this is the patient disposition, and it was pretty, uniform. You can see the randomization in terms of ITT and the patients who were treated. Also, in terms of patients who were alive and on study, there would be a difference in terms of the disease outcome. And the patients who were discontinued in the study were obviously less in the Kadcyla arm, and prior to IDFS events also were slightly less in the Kadcyla arm. Next slide. So baseline characteristics pretty well matched, whether in terms of the clinical stage or in terms of the hormone status, in terms of ER/PR, in terms of the whatever HER2 directed therapy was received, which was either trastuzumab alone or trastuzumab with pertuzumab. A very important confounding factor, whether it was a bad disease in terms of node positivity or a node negativity, and also in terms of whether a prior anthracycline was used or not. Next. So this was the median follow-up after 8.4 years. And you can see here, the graphs tended to separate wider in terms of the IDFS. So you had something like an 11% difference at the end of 3 years, which increased to about 12.2 at the end of 5 years, and then subsequently it increased to more than around 13% when you saw the data at the end of 7 years, and this was all statistically significant. Next. So we now come on to the final IDFS analysis in terms of the subgroups. And you see the forest plot down, you see that most of the, nearly all subgroups are benefiting with the, the group which was receiving Cat-Kaila. And the significant ones are the ones which are with the clinical age stage at presentation, which is inoperable or operable. So even the operable stage is benefiting, whether the hormone status is negative or positive, whether the patient had received trastuzumab or trastuzumab plus pertuzumab, or whether the patient is node positive or node negative. And even in terms of the HER2 status by IHC, you can see here even the 2+ population with FISH positivity is benefiting. Next. Now, in terms of the regional lymph node and the primary tumor stage, in terms of the pathological response, still you see that the graph is all towards the Cat-Kaila. And even in terms of the age group, whether it is the young less than 40 and more than 65, everything is in the favor of the Cat-Kaila arm. Next. So the site of first occurrence of an IDFS event. So you see there is a gross difference between the total number of patients with IDFS events, also in terms of the distant occurrence. But an important point over here is the CNS recurrence. And CNS recurrence is a concern in the patients who have been receiving Cat-Kaila. The numbers are though less as compared to trastuzumab, but they are significant. Now, in terms of the loco-regional recurrence, contralateral breast cancer, and death without prior event, everything is in the favor of the Cat-Kaila arm. The death without prior event does not make any major difference. Next. Okay, now second OS interim analysis. So what we saw was that the graphs had started to separate. Now the graphs have actually separated wide. And there was a difference of about 5%, 4.7% to be in absolute terms. And the number of events were about 12% versus 17% for in the favor of the Cat-Kaila arm, with a hazard ratio of 0.66. Next slide. So if you see the summary of deaths, they were much less in the case of the Cat-Kaila arm, and the specific cause of death being either breast cancer or others were, the breast cancer specific cause of death was less in the Cat-Kaila arm. The adverse events were nearly negligible in both the arms, and others were also nearly similar. Next. So this was the subgroup analysis in terms of the second OS interim analysis, and this OS interim analysis also showed that the Cat-Kaila was doing much better than the trastuzumab in this specific subgroup, and everything was towards in favor of the Cat-Kaila arm. Next. Okay, and this was again the replication of the first interim OS analysis as well, the IDFS analysis, everything in favor of the Cat-Kaila arm, whether it was the pathological response or the age group again. Next slide. So now coming on to the follow-up medication which was received after IDFS events and the total number of events. So you can see the total number of IDFS events were much higher in the trastuzumab arm as compared to the Cat-Kaila arm. And also in terms of the HER2-directed therapy which was received subsequently, which was obviously would be something of a source of what has been received prior, would be the way it would be given. So, no major difference in those terms. Next slide. Okay, now coming on to the adverse events, and there was no new safety signal, and there were no real adverse events leading on to death. However, there are some specific side effects for both the drugs. However, the point to be noted over here was that cardiac morbidity was minimal in both the cases, so it was not really a matter of concern. Next slide. So the Catherine came on to the conclusion that after 8.4 years median follow-up, there was a significantly improved OS in early breast cancer with residual invasive disease after NACT, hazard ratio of 0.66. The 7-year OS rate was 89.1 versus 84.4, a difference of 4.7%, which translated to a benefit of about a 40% reduction in terms of death. IDFS benefit was sustained in the ITT population with longer follow-up, hazard ratio of 0.44, a 46% benefit, again excellent. 7-year IDFS was 80.8 versus 67.1. Cardiac toxicity was rare in both the cases, and Kadcyla was the first therapy to show an improved survival post-surgery in patients with HER2-positive early breast cancer with residual invasive disease after NACT. Follow-up is ongoing for the final OS analysis. I also want to make a point over here. There was a subset which had actually converted to HER2 negative post-NACT. It was seen on giving Kadcyla in that subgroup as well, the patients were benefiting. So it really didn't make a difference whether the patient had converted into a HER2 negative post-NACT. The only subgroup which was creating a problem was those of the CNS mets, because we know that the CNS activity of both of these drugs is not really very good. Next slide. Okay. So with that, thank you, and back to the organizers.
Yeah, thank you, Dr. Mohit. I've been informed by the organizers we are running almost 20 minutes late, so we'll put questions later on. So moving on
Sure.
further, I would invite Dr. Venugopal Aruju from Hyderabad. He's a senior consultant medical oncologist at Pi Healthcare Cancer Hospital in Hyderabad, and he would be talking on the Olympia A trial. Is a phase 3 clinical trial that demonstrated the adjuvant olaparib, the use of adjuvant olaparib in early breast cancer. So over to you, Dr. Venugopal.
Yeah. So, hi everyone. Good evening. I thank organizers for giving me the opportunity to present this one. So, Geetika, should I share the slide deck?
Sure, sir. You can
Yeah,
share the
sure,
slides.
sir. Give me 1 minute, sir.
Yeah, if it is possible, this is okay. You are able to see my screen?
No, sir.
Oh, okay. Yeah. Can you just share then?
Yeah, we can see your slides.
If it is feasible, I'll share. Geetika.
Yes, sir. It's visible now.
Yeah. Then, fine. So I thank the organizers for giving me this opportunity. Yeah. So basically, I'll be presenting on the updated analysis of the Olympia trial presented at SABCS 2024. Somehow I am not able to move the slide deck here.
Ritika, I would prefer if you share the slides because it
Yes,
becomes
sure,
easier
sir. I can.
shifting the slides.
Yeah, fine. So I'll continue. So these are the partners involved in conducting Olympia. So basically, as we know that Olympia uniquely examined olaparib as adjuvant therapy in patients with germline BRCA positive and high risk early HER2 negative breast cancer. So now we are going to discuss about the updated analysis. So these are the results of the third pre-specified analysis at 10 years from the first patient in, with a median follow-up of around close to 6.1 years, and an additional 2.6 years follow-up since the previous analysis. So this is the schema as we know well. So germline pathogenic or likely pathogenic BRCA1 2 HER2 negative, ER positive or triple negative breast cancer, stage 2, stage 3 breast cancer, or lack of PAT-CR to the neoadjuvant chemotherapy. And of course, we all know about the neoadjuvant group, with TNBC group having non-PCR and ERPR positive group having non-PCR and CPS plus EG score more than or equal to 3. In the adjuvant group, TNBC with node positive disease, T2 or more than T2 size tumor, and ERP positive tumors, 4 or more than BD for 1 year versus placebo. And the stratification factor is
Dr. Gurudat, your voice is cracking in between.
%, BRCA2 28%, premenopausal were 60. 2%.
Hello.
Hello,
Venu sir, your voice is not.
Dr. Venu, your voice is not audible. Dr. Venugopal, your voice is not audible. Team, can somebody help Dr. Venugopal?
Sir, he is connecting to audio, sir, na?
Sir is rejoining in 1 minute, sir.
Okay.
Yeah, is it audible? No?
Yeah, now it's better.
Okay.
Dr. Venu, again, some issues with your.
Is it visible now? Hello?
Yeah, it's better. Yeah.
Is it visible and audible? Let me know, please.
Yeah, your slides are visible,
Hello?
but your voice is cracking in between.
Sir, your slides are shared by Gitika. Kindly you can check on the
Okay.
Zoom screen. And just I have to ask her like for the next slide. She just move your slides.
Oh, okay. So I just came out of this slide sharing. You can go ahead, Gitika.
Yes, sir.
Next slide.
Yeah, this we have already covered. Next slide. Yeah, next slide. Next slide, please. Next slide. Yeah. So here, so whole ITT IDFS analysis shows that 6-year IDFS rates are absolute difference being 9.4% for olaparib versus placebo, hazards being 0.65. So definitely there is significantly improvement, statistically significant improvement in terms of IDFS with olaparib versus placebo. Next slide. Yeah. So this is the subgroup analysis. So all subgroups fared better in terms of prior chemo received, adjuvant or neoadjuvant chemo, prior platinum received versus not received, and the BRCA mutational status as well as TNBC versus ERPR positive subgroup. So all subgroups favored better with olaparib, as we can see here, stratified hazard ratio being 0.65 to 0.75. Yeah, next slide. And if you look in terms of the HR status, IDFS by HR status, so both triple negative TNBC as well as ERPR positive hazards are 0.65 and 0.68. So irrespective of the hormonal status, so whether it is TNBC or ERPR positive, they fared better with adjuvant olaparib. Next slide. And distant DFS for whole ITT, 6-year DDFS rate, absolute difference is 7.8% and hazards ratio being 0.65. So again, showing the same continued benefit what we saw in the second analysis. Next slide. Again, all the key subgroups benefited with olaparib compared to the placebo, irrespective of the prior chemos, neoadjuvant chemo, or hormone receptor TNBC, or hormone positive BRCA mutational status. Irrespective of all these key subgroups fared better with the olaparib. Next slide. Yeah, so the total number of deaths, 11.6% versus 15.6%, and the primary cause of death, breast cancer recurrence, is seen in around 94%, 94 patients, 10% versus 14% in the placebo. And other causes, of course, as it is mentioned here, so other cancers like pancreatic carcinoma, AML, acute myeloid leukemia, cardiovascular deaths, and MODS, neutropenic sepsis were seen olaparib arms compared to other causes in the placebo. Slide. Yeah, this is the analysis of overall survival in the ITT population. 6-year OS rates, absolute difference being 4.4% and hazards being 0.72. So the significant, definitely improvement in terms of the OS rates, but the final OS analysis is awaited in the 2029. Next slide. So again, this is the fared better by placebo in terms of the analysis of the OS, overall survival. Yeah, next slide. So if you look in adverse of special interest, so MDS, AML, pneumonitis, new primary malignancies, so these were the events of special interest. But when we look at the overall conclusions, so MDS, AML rates were not higher with olaparib as contrary to expectations, and pneumonitis 1% in olaparib arm versus 1.4%. The new primary malignancies 4.9% in the olaparib arm versus 7.5% with the placebo. So telling us that no increased rates of primary malignancies as MDS AML with the olaparib. So the new primary malignancies, 4.9% in olaparib versus 7.5. In fact, number wise, if you look, primary malignancies new were less in olaparib. So almost no difference in terms of the new primary malignancies with olaparib usage as per this analysis as well. Next slide. Yeah, in the similar way, if you look in terms of contralateral invasive breast cancer, 34 versus 42, and non-invasive breast cancer, 3 versus 4, and new primary ovarian or fallopian tube cancers, 5 versus 14, olaparib or placebo respectively, again telling us that there is no increased malignancy percentage or frequency with olaparib here as per this analysis. Next slide. And the number of pregnancies, again, 51 and 51. Yeah, next slide. On study pregnancies. So the conclusions here, at 6.1 years median follow-up and maximum being 9.6 years in this analysis. So 1 year of olaparib after adjuvant chemo continues to demonstrate clinically meaningful improvement in terms of IDFS, DDFS, and OS in these patients with BRCA germinal BRCA positive and high-risk HER2 negative primary breast cancer. And all key subgroups have done better with olaparib. fewer new primary malignancies, and no evidence of increased risk of MDS or AML in this population. So overall survival is avoided from June 2029 analysis. So this is the latest updated analysis which is presented. Thank you.
Thank you, Dr. Venugopal. In the interest of time, I would like to move ahead, and I would like to invite Dr. Vineet Govind Gupta. He is an additional director and unit head of medical oncology at Fortis Hospital, Shalimar Bagh, and he'll give us an update of the results of the phase 3 EMBER-3 trial of imlunestrant as an oral selective estrogen receptor degrader as a single agent in ER positive, HER2 negative advanced breast cancers. Dr. Vineet, over to you. Geetika, can we share his slides, please?
Hello.
Yeah, hi, Dr. Vineet.
Yeah, hi. Good evening,
Good
sir.
evening.
Yeah. Last up, 2 minutes wait karo. Thank you. Yeah, hi. Good evening, sir. So yeah, so thank you very much for inviting me to today's meeting.
Yeah.
So I'm going to present this very important paper. So now it is also published in NEGM, and I think it is practice-changing paper. So it is imlunestrant, which is a oral SERD in frontline advanced breast cancer. So in second-line advanced breast cancer, a patient treated with endocrine therapy, the phase 3 EMBER-3 study. Next slide, please. So yeah, so the basic background of the study is, so it is somewhat similar to the EMBERALD study. We are looking at a SERD in the second line. And critically, currently, the main backbone of treatment for hormone-positive patient is endocrine therapy with CDK4/6 inhibition. And the basic idea is once patient progresses on aromatase inhibitor, usually the next line has been classically fulvestrant. But fulvestrant has many problems. Number one, it is not that effective in ESR1 mutant patient, and good proportion of patient will be ESR1 mutant in the second line. You can see in the graph to the top. If you look at the tumor volume reduction, you can see fulvestrant is the gray line. So it is just okay compared to black line, which is the placebo. Well, imlunestrant, you can see that it has got a very good response in terms of tumor volume reduction, indicating its higher potency. Second is it's an intramuscular injection. So I have a patient actually who is on fulvestrant for last 2 years, and the buttock of the patient is completely flat. And patient always shouts with pain whenever she gets the injection. So unfortunately, you have to give it in the buttock. It is painful and troublesome for the patient. So elacestrant is already approved for ESR1 mutant patient, which is an orally active SERD. And now we have got imlunestrant, which is a next generation brain penetrant drug, which is an oral SERD and pure ER antagonist. So, sorry. Next slide, please. Yeah, so this is the basic outline of the study. So you have got men and women, which can be pre or postmenopausal, and they had to have prior therapy with adjuvant. So either they had to have endocrine resistant adjuvant hormone therapy, or in advanced setting, they had to have progression on first line aromatase inhibitor with or without CDK4/6 antagonist, and no other therapy for advanced breast cancer, randomized to imlunestrant versus fulvestrant or exemestane, which is the standard of care, and imlunestrant with abemaciclib. And primary endpoint is PFS for imlunestrant versus SOC, imlunestrant versus SOC in ESR1 mutant, and imlunestrant abemaciclib versus imlunestrant, and various efficacy and safety endpoint. Next slide. We'll just leave the statistical consideration. Next slide. Next slide, please. Yeah, so out of 874 patients, roughly 330 were randomized to imlunestrant and SOC, while the imlunestrant abemaciclib had 213 patients. So what was the reason for this? Is that there was a protocol amendment, which and the randomization to this arm was started later. So because of that, the number of patients are lower in the imlunestrant abemaciclib arm. Next slide. Yeah, if you look at baseline demographic, they are well matched. One thing you might be interested in is the ESR1 mutation percentage. And you can see that roughly 35 to 40% of patients were ESR1 positive in all three arms. And PIK3CA mutation also you can see around 40% of patients in all three arms. Next slide. Yeah, so this is the primary endpoint, number one, which is imlunestrant versus SOC in ESR1 mutant patient. You can see it is, there is a hazard ratio of 0.62 with a median PFS of 5.5. So it is not that impressive. Definitely it is 38% better PFS. But if you compare it to Emerald, next slide. So if you compare it to Emerald study, it is almost the same. Emerald study had hazard ratio of 0. Next slide, please. Hazard ratio of 0.55. So it is almost similar. But interesting thing here is almost every subgroup is benefiting. You can see that 90% or so patient got fulvestrant, and all of them are, and even the patient who got exemestane, the benefit favors imlunestrant versus standard of care, indicating that it is effective for all kind of patient, whether they are visceral mets, prior CDK4/6 inhibitor, or even PIK3CA pathway mutation. Next slide. So in all patients, there is a hazard ratio of 0.87, but it did not meet statistical significance, indicating it is not that useful in ESR1 negative patient. So again, it is similar to elacestrant, where main benefit is in ESR1 mutant patient. There is some separation of curves, but it is not as impressive. So not meeting this endpoint. Next slide. And what about the thing we are most interested in? What about patient who got abemaciclib and imlunestrant? So you can see here, the hazard ratio is very, very decent. It is 0.57. And at 1 year, it is 42% versus 27% progression free, and 9.4 versus 5.5. So a reasonably good difference in the efficacy, indicating meeting of this endpoint. So imlunestrant is better than standard in ESR1 mutant patient. And imlunestrant abemaciclib is even better than imlunestrant, indicating that it's a good option for these patients. This is the first trial where I have seen combination of novel SERD with CDK4/6 inhibitor. Next slide. And again, you can see all the subgroup are benefiting. Even the patient who have received previous CDK4/6 inhibitor, I want you to see this box. Patient who have got it, they actually seem to be doing better. You can see somebody who has got prior CDK4/6, the hazard ratio is 0.5. So even if patient has already got palbociclib or something, you can give the next line imlunestrant with abemaciclib, and still patient will benefit. You can see here ESR1 mutant patient, they also benefit. Patient with without ESR1 also benefit. Next slide. Next slide, please. And whether patient got prior CDK4/6 or whether they have PIK3CA mutation, all of them are benefiting with addition of abemaciclib. Next slide. Next slide, please. Yeah, so if you look at the overall response rate, you can see here, I want you to see the bottom line. In ESR1 mutant, ORR is 35%. So that's a very decent response rate actually. So one thing I always tell to my students is hormone therapy has just response rate like this only. So don't think you will get 90-95% response rate in hormone therapy. In fact, Enhertu has response rate higher than any hormone therapy in second line. So Enhertu has a 65% response rate. So 35% with imlunestrant with abemaciclib is quite decent in the ESR1 mutant population. Next slide. So one important thing about imlunestrant, it is a brain penetrating drug. So a lot of the hormone therapies don't penetrate the CNS, and imlunestrant does penetrate the CNS. And you can see that even among patients with ESR1 mutation, it reduces the cumulative incidence of brain mets. So I think that is very, very important for the future, because a lot of these patients will come with brain mets after some time. Next slide. And overall survival is not yet mature, but you can see that the signals seem to be stronger in ESR1 mutant patient compared to all patients, and possibly you will see it becoming mature over time because it is an effective therapy. Probably, I think you will want to use it with CDK4/6 inhibitor. Next slide. And very, very important, tolerability. So it is a very tolerable drug. You can see imlunestrant versus fulvestrant. It is 21 versus 17 patients with more than one adverse event in terms of percentage. And none of the grade 3 side effect is more than 2% except anemia. So very, very safe drug. And even with imlunestrant with abemaciclib, the main Grade 3 side effects are toxicity of abemaciclib, like diarrhea, nausea, neutropenia, and anemia, and fatigue. So possibly you are not having that much toxicity because of imlunestrant, and mostly it is well tolerated by patients. Next slide. So just to conclude, monotherapy proven to improve PFS in ESR1 mutant patient, but not in overall population. OS is showing favorable signal, but analysis is ongoing. And it is a very relatively safe drug, I would say. And as for imlunestrant with abemaciclib, there is an improvement in PFS, which is very, very nice compared to imlunestrant. So 0.57 hazard ratio on top of 0.62 over fulvestrant, and 9.4 months PFS, which is a very, very good signal. So a lot of the drugs like alpelisib also achieved good hazard ratio, but I think none of them are so non-toxic, like you have seen in this study. You can see in the previous slide that rate of drug discontinuation only 6%. So if you go for to the Pluvicto trial, it is almost 25%. So it indicates a high safety profile for this combination, and it is a predictable and good safety with this combination. So possibly it will be the standard of care for ESR1 positive patient. You also have option of elacestrant, but there is no data for elacestrant with abemaciclib or any other CDK4/6 inhibitor. Now, for the first time, you have data for novel SERD with CDK4/6 inhibitor, indicating better times for our hormone positive patients. Next slide. I think we'll end with that. I think this is the last slide. Thank you very much.
Thank you, Dr. Vineet, for keeping it on time and wrapping up very early. There's lots to be discussed on this paper. It's a very important drug and a game changer. But with the limitation of time, I would proceed further and invite Dr. Mohit Agarwal again, for a neoadjuvant management and adaptive strategies for breast cancer. Dr. Mohit.
Yeah. So thank you. So again, for the benefit of time, I'll just start with my presentation. So it's about the neoadjuvant management and adaptive strategies in bioadaptation. I'll talk about it right now. Next slide. So let us see how the HER2 positive disease has changed. And we see without the HER2 positive disease, the terms of survival probability, and when you give a HER2 based treatment, the possibility of a survival. So this is how much a difference this HER2 based treatment has made in terms of a breast cancer. Next. So these are the new agents for HER2 positive breast cancer. I'm not going into details. We are all aware of it. Next. So now why neoadjuvant? And this question is very standard. We know that we have a reduced tumor size and axillary involvement to increase the chances of a breast conserving surgery and axillary sparing, treatment monitoring and treatment adaptation, early treatment of metastatic disease. But what is important in HER2 positive breast cancer is to guide the adjuvant treatment decisions, because this is something which we have seen has made a difference when we give NACT in HER2 positive breast cancer. And it's obviously an early endpoints for all clinical trials. Next. So when we talk about the RCB, you see here, even in a HER2 positive breast cancer, whether it is an ER positive or an ER negative, when you have an RCB 0, the line is usually really flat in terms of the survival and an event-free survival. By the moment you come to RCB 1, 2, 3, the graph starts going down. So when you receive something like a pathological CR, the RCB of 0, the patients tend to do very well. So our goal is to achieve a pathological CR. Next. So this was a Neosphere study which had actually shown that when you increase, when you add pertuzumab to the combination of trastuzumab and taxane, it increases the PCR and the progression-free survival. And this was in a tune of 29 from 29 in the non-pertuzumab group to 45%. This was an amount of which was increased, about 16% increase in the pathological CR. And we have seen in the previous slide that how the pathological CR actually matters in terms of survival. Next slide. So we had a Christine trial, and this was basically to see that whether we can really do something better than a TCHP regimen, which we given in NACT, though they tried a TDM with a pertuzumab, but the results were inferior, and actually the TCHP arm did much better with 6 cycles achieving a 90% event-free survival, and the TDM arm did not do so well. Next slide. Okay, now we had train 2 study and we had seen very safely that if we omit anthracyclines, we can actually achieve an event-free survival equivalent to that with an anthracycline-based regimen. And we know that anthracyclines have their baggage along with it. So we can very well go for an anthracycline regimen on the basis of train 2, BCIRG 006 and Trifina. So equally effective and less toxic. Next slide. So what is the current practice? We go with something like a taxane platinum with trastuzumab and pertuzumab, achieve an event-free survival of about 85 to 95%. We think in terms of anthracycline cyclophosphamide in only those patients who do not respond in interim analysis, or they relapse, or they have some sort of an intratumoral heterogeneity. And now the next question comes about endocrine therapy. So I have a very interesting slide, the next study. Next slide. So this is a very interesting trial, the NACPPP B52. It was in a hormone positive, HER2 positive breast cancer, and they gave TCHP or a TCHP along with a hormone. And next slide. Interestingly, the arm which had contained an anti-endocrine therapy did better in terms of the pathological CR, but was only a numerical improvement. It was not statistically significant, hence it was not really incorporated. But then we really questioned and challenged the way we used to think that basically the endocrine therapy would be antagonistic to a chemotherapy-based therapy, but this did not happen in this trial. Next slide. So we have two questions to address, and one is that we achieve an EFS of 85 to 95%. So what about those 10% patients who relapse? How do we improve their efficacy? And for those 90% of the patients who have a very good EFS, can we actually reduce the treatment burden or to lesser duration or to a chemotherapy-free regimen so as to make them a better quality of life? Next slide. So these are the factors on which we can take a call. This is in terms of HER2 3+ or a 2+ ish positive, ITH, or a adapt prognostic score, a HER2 DX PCR score, or something like a molecular subtyping of HER2 on a basis of PAM50. Next slide. And then you have some trials and the train 2, which had shown that the tumor infiltrating lymphocytes in HER2 positive early breast cancer makes a difference, and there was improvement in those who are having a more TIL, which in terms of the IDFS. So these are some of the factors which can be taken into account as to decide up to what where you can actually step down your treatment or step up. Next slide. Can I have the next?
Think so,
Strike a
Boris.
connection in between. So these are some, yeah, I'm back. Yeah. So these are some of the selected trials which have actually tried to do so in terms of a risk adapted approach, in terms of de-escalating or escalating, which would be Ariadne, WSG Adapt, and Destiny Breast 11. I'm not going into the details of the same. Next slide. Yeah, so train 3 has already been discussed in detail by one of our previous speaker. The only thing to be noted down over here, MRI is a very sensitive modality, especially in a HER2 hormone receptor negative disease, to assess the radiological complete response. So this something can be taken into consideration. Next slide. What also was ascertained through train 3 was that early PCR was very common, and 1 in 3 patients, that is 33 patients, percent of the patients actually achieved a PCR only after 3 cycles. You really need not go to 6 or more than that. And with 3 achieving a PCR, you can really modify the treatment later on. Next slide. So question is, can we omit chemotherapy? And we have had various studies again, Neosphere, PCR 17%, ADAPT 36%, Paralyza 20%, and Fergain, a very interesting study which has now started with Fergain 2 as well, a PCR of about 38%. Next slide. So this was a Ferguson study, an interesting study where you actually just go for a 2 cycles of chemotherapy, see for the response. If the response is there, just go for a 6 cycles of chemotherapy without chemotherapy and only anti-HER2 and endocrine therapy if required. If no response, continue all the 6 cycles and then subsequently decide in terms of a surgery. If a pathological CR is achieved, no chemotherapy given, again, only with endocrine and anti-HER2 therapy. However, in the case of a non-pathological CR, complete your TCHP. So here what was realized was that about, again, 33% of the patients achieve PCR without chemotherapy and then had an excellent 3-year IDFS. So you mean to say that 1 out of every 3 patients can be spared of a chemotherapy, something again very remarkable and maybe something a future call where we would be treating our patients in this way. Next slide. So this is the Ferguson 2 study, and just wanted to mention the inclusion criteria over here. So it is HER2 positive, score 3+ only, no 2+ FISH positive, and again tumor size between 5 to 25 mm. Again, I'm not going to the details of the study, but something like a Ferguson study only. Next slide. So what can be the potential treatment algorithm? Whenever you have a stage 2-3 HER2 positive breast cancer, you assess the risk. If you find the risk to be very good, you de-escalate it and go with the chemotherapy-free regimen. Go for a response evaluation. If the response is good, continue with the chemotherapy-free regimen. However, if the response is not there or you feel that is suboptimal response, then escalate the treatment. And then you can take a further call onto the treatment post-surgery on the basis of RCB or ctDNA. Next slide. This is the new iSpire design. I'm not going to the details of the same. Next slide. So these are some of the, again, the optimization trials in HER2 positive, where they have tried different new molecules in terms of the response. Next slide. So in summary, the new adjuvant approach is standard of care for stage 2-3 HER2 positive. As of now, TCHP, taxane, platinum, trastuzumab, pertuzumab is the preferred regimen. We can go for a baseline IHC molecular markers and see the outcomes. You can identify an early complete response if hormone receptor negative in an MRI, and adaptive treatment algorithms may help to maximize efficacy and quality of life. Adaptive trial designs may help to advance new developments, and this is the future of, I think, the HER2-based treatment in early or locally advanced breast cancer. Thank you.
Thank you, Dr. Mohit. And again, sticking to time, really an interesting study. And this is something which we are looking forward in our practice and waiting for future data to come. So now inviting Dr. Sohail Qureshi, who's again an additional director and unit head of medical oncology at Fortis Hospital, Shalimar Bagh. And he'll be talking on a flexible future that is transforming the paradigm of HER2 plus positive breast cancer treatment. So, Dr. Sohail, over to you.
Thank you very much, sir. I hope I'm audible to everybody. And thank you very much to Dr. Bhargava, sir, for giving me this opportunity. I'll just quickly share my slides. Is my screen visible to everyone?
Yes. Yeah.
Okay, so this is a sponsored session from Roche. That is my only disclaimer, and I'll keep it short and crisp. So I'm going to be talking about the impact of subcutaneous dual HER2 blockade on patients with HER2 positive breast cancer. Dr. Mohit has made my task slightly easier, as he has stressed upon why achieving a PATH CR is important. And how that translates into better patient outcomes. So this slide shows the real world evidence as well as a meta-analysis study of how achieving a PCR with neoadjuvant chemotherapy results in longer survival benefit versus those patients who have a residual disease. So as you can see in this, the Kaplan-Meier curves, that those patients in the graph on the upper half of your screen is the event-free survival, and on the lower half are the overall survival. The patients who achieve PATH-CR with neoadjuvant therapy perform far better as compared to those who have a residual disease, and there's a daylight of a difference between them in terms of survival, OS, as well as EFS. Historically, we have seen across the board when only trastuzumab was available as one of the neoadjuvant strategies in the early 2000s, that the pathological complete responses were in the tune of around 38 to 39, at best 40%, with the use of trastuzumab. At that point in time, anthracycline was an integral part of the neoadjuvant protocols. And as we moved forward and pertuzumab became available in the late 2010s, the responses with the dual anti-HER2 blockade were far more superior, to the tune of around 56 to 60%. And they've actually gone on to redefine the patient outcomes far more with this dual anti-HER2 blockade. And with the TRAIN2 and GEPAR-SEPTO, we've seen these PATCR rates climbing to almost 70%. And that has resulted in a paradigm shift in how we look at these patients today. So again, patients receiving neoadjuvant dual HER2/neu blockade have improved EFS. So this slide I'll divide into two parts. The upper half is the patients regardless of PATCR. So if those patients in all comers with only trastuzumab being the partner in the neoadjuvant as well as the adjuvant sphere, the event-free survival was to the tune of 69%. There, you see it here. When pertuzumab became available and we started using pertuzumab in the neosphere and the Trifina studies in the neoadjuvant space, this event-free survival went up to the tune of 82%. And when we started using this anti-HER2 blockade strategy in the neoadjuvant as well as the adjuvant sphere in the Berenice and the Christine trials, this actually went up to 94%. That's a staggering number. And this is regardless of PATCR. These numbers become even more impressive when I talk about, in the lower half of the slide, patients who achieve a PATCR. So in patients who achieve a PATCR with only trastuzumab in both these settings, neoadjuvant as well as adjuvant, the EFS rate is around 87%. With the advent of pertuzumab, this goes up to 92%. And when pertuzumab is used in both the spheres, neoadjuvant as well as adjuvant, this goes to a whopping 95% EFS rate. So that is phenomenally great. So this is a pooled analysis of event-free survival in patients with HER2-positive early breast cancer with a pathological complete response after HER2-targeted therapy, and actually shows that regardless of the pathological complete response status, the reduction in EFS is far greater in patients who are administered pertuzumab in both the settings, that is, neoadjuvant as well as the adjuvant setting, and these patients do remarkably well. So there was always concerns about the cardiotoxicity of dual anti-HER2 blockade, since this was an era when adriamycin or anthracyclines was still in vogue for the neoadjuvant strategies. And this Berenice study actually evaluated cardiac safety of this particular approach. And there were two cohorts. The first cohort consisted of dose-dense AC followed by dual anti-HER2 blockade with pertuzumab and trastuzumab and taxanes. And in cohort B, it was FEC followed by docetaxel and dual HER2 blockade. And this study showed that the graphs were actually neck and neck, and there were similar adverse events in both the cohorts. And if you would see here, then in the whole study, the fall in ejection fraction to a value less than 50% was actually similar in both these cohorts, and therefore no new safety signals with respect to cardiotoxicity was observed when anti-HER2 therapy was as a doublet was used. This is the phase 3 Peony trial, which evaluated the efficacy, safety, and tolerability of this dual anti-HER2 approach, and no new safety signals except for the fact that of the most common adverse events in the IV formulation, diarrhea was more common in the dual anti-HER2 blockage, 40% versus 17% in the placebo arm. Otherwise, the EFS, the disease-free survival, and the OS were supportive of the dual anti-HER2 therapy predominantly with respect to the placebo. So having established that dual anti-HER2 neoadjuvant approach of pertuzumab and trastuzumab is the way forward and the standard of care, what is the current status of dual HER2 blockade as we know today? So this is the screenshot from NCCN guidelines 2024 version, that TCHP, as Dr. Mohit has already told us, is actually the category 1 preferred regimen for neoadjuvant therapy for all the patients who have early breast cancer. If, however, the patients do not have a pathological complete response or they have a residual disease after this preoperative therapy, then TDM1 is a category 1 recommendation. The important thing being that if patients were node positive at the initial staging, then regardless of whether they achieve a PAT-CR, if the patients were node positive, then even if they achieve a PAT-CR, then the trastuzumab and pertuzumab combination is a category 1 recommendation, and one would be skeptical of de-escalating these patients to only trastuzumab, even if they were to achieve a pathological complete response. Similar to what we saw in the neoadjuvant sphere, the adjuvant sphere is also in patients of hormone positive, HER2 positive disease. So in triple positive, if the patients have undergone surgery upfront and have node positive disease, then adjuvant chemotherapy along with a doublet of trastuzumab and pertuzumab and endocrine therapy is the preferred category 1 way forward. And in patients who are hormone receptor negative but HER2 positive in the adjuvant sphere, again, in node positive disease, the preferred category 1 option is a combination of dual anti-HER2 therapy along with adjuvant chemotherapy. In the metastatic sphere, this is all again what we see, that a combination of pertuzumab, trastuzumab along with a taxane, whether it is docetaxel or paclitaxel, is a category 1 recommendation. So ESMO guidelines, a similar endorsement of what we've already seen with NCCN. So we know that the process of receiving intravenous therapy with chemotherapy as well as anti-HER2 therapy imposes a significant burden on the life of the patient and as well as the family, and so also the finances. Despite the fact that the patients have completed their chemotherapy and their surgery, they would require to come to the hospital for IV infusion therapies. And these actually place a significant burden on the lives of the patient, including psychological and physical discomfort and logistical burden of keeping up the appointments with the doctor, getting in the line for daycare admissions, and so on and so forth. So this actually compounds their misery because the patients just never end up coming to the hospital, and every time they come and the time on their minds. I had a patient who told me that, sir, whenever I do come to the daycare for my IV pertuzumab and trastuzumab, whenever I touch my chemo port, it brings back really bad memories of the time when I was diagnosed with cancer, even though today I'm cancer free and I have already achieved a PAT-CR. So this actually is an emotional discomfort, and there are a lot of personal milestones to be attended to, including small children, their different milestones in school and so on, and working status for young patients. Travel time in cities like Delhi and Mumbai, it's actually a difficult time traveling to the hospital and back. So these are practical issues that need to be taken into the consideration, because coming to the hospital is just one thing that we actually see. The travel time, the blood test, the waiting time, the meeting other patients, and the insertion of the cannula. And if the cannula is not there, then the venous access devices, all of these impose a very long and considerable impact on the patient's quality of life. So these logistical challenges result in a range of negative emotions, including anxiety, frustration, guilt, isolation, and so on, as I've just discussed. And in studies which have been done to assess the impact of these negative emotions, it has been shown categorically that depression was associated with cancer recurrence, all-cause mortality, as well as cancer-specific mortality. And this comorbidity of depression as well as anxiety is associated with an all-cause mortality and cancer-specific mortality. So this kind of is obviated by a newer preparation of subcutaneous pertuzumab and trastuzumab combination, which avoids the long infusion and observation time and the congestion at crowded daycares and hospitals. It also helps us to improve the challenging situations of improving resource utilization. The chair time is actually reduced in the daycare. You can actually, allocate that chair even after just after half an hour to a new patient once the FESCO administration has been completed. It avoids the placement or maintenance of indwelling venous catheters, whether it is a cannula or a PICC line or a central venous catheter. Also avoids the side effects which these catheters might bring with them, which includes venous thrombosis and the risk of infection and so on. And the challenge of venous access in the patients is also taken care of, since the subcutaneous formulation of FESGO avoids that particular aspect as well. So Phesgo is actually the first formulation in oncology to combine two different monoclonal antibodies, which is pertuzumab and trastuzumab in a single injection. Contains the same antibodies which have been approved for the IV use, but have a different route of administration, which is subcutaneous. It is formulated with recombinant human hyaluronidase injection to allow for subcutaneous administration of higher drug volumes in the subcutaneous space without compromising efficacy. And is a ready-to-use FDC, fixed dose combination formulation administered by a subcutaneous injection in the anterior thigh compartment over approximately 8 to 10 minutes. So these two studies, the Federica and Francesca, actually went on to show that that the pharmacokinetic profile of the subcutaneous formulation was pretty much comparable to the IV formulation, and the Federica study demonstrated a non-inferiority of the serum C-trough concentration of pertuzumab as well as the trastuzumab within the subcutaneous as well as versus the IV formulations. The PATH-CR rates were almost identical between the two treatment arms, and the subcutaneous Phesgo formulation was reasonably well tolerated and safe as compared to those who received the IV pertuzumab and trastuzumab combination. The Francesca analysis showed that almost 85% of patients preferred the Phesgo subcutaneous formulation over the IV individual pertuzumab and trastuzumab combination. And after a long-term follow-up, although the efficacy data still remains immature, but the high 3-year IDFS and OS rates were seen in the Phesgo formulation vis-a-vis the IV formulation. Not just that, the adverse events were reasonably comparable between the two arms of IV as well as the subcutaneous, except for some injection site reactions. Diarrhea, in fact, was lesser in the subcutaneous Phesgo formulation, but the numbers were too small to actually make a very solid interpretation that must be interpreted with caution. So not just that, it also imposes a less emotional distress to the patients, and 93% of patients who preferred Phesgo had a very strong or a fairly strong preference at the primary analysis. And the main reason in the PREFER2 study said that the main reasons for preferring the subcutaneous administration over the IV was requiring less time in the clinic and feeling more comfortable during its administration, which is fairly consistent with what we also observe in our OPDs every day. Not just that, even the healthcare providers felt similarly that switching from the IV formulation to the subcutaneous formulation would save time and resources during the preparation as well as the treatment. And this was reasonably felt across the board with all the stakeholders, which includes the chemotherapy nurses, the hospital staff, the healthcare providers, and as well as the patient's family members. So almost 2 out of 3 patients felt restricted while using the IV formulation versus only 27% when receiving the Phesgo formulation, again going in favor of the subcutaneous formulation being the winner outrightly here. So I would conclude by saying that free from lines and free from far away from fear, the subcutaneous combination of Phesgo is here to stay with dual HER2 blockade and to redefine our patient outcomes. Thank you very much.
Thank you, Dr. Sohail. We are also looking forward for oral HER2 blockade coming in future. So that will again be a game changer. So in the interest of time, I would like to bypass my session and invite Dr. Mohit Saxena, who would be talking on the Padma study, which is a long-term follow-up of endocrine therapy plus palbociclib. So Dr. Mohit Saxena, he's a consultant medical oncologist and hematologist at Manipal Hospital. So Dr. Mohit, over to you.
Sir, good evening, sir. Thanks for giving me the opportunity. Let me share my screen. Yeah, it is. I think it is visible. So, yeah. So that just wait for a minute. Yeah, the topic given to me is primary result of the randomized phase 4 trial comparing first-line endocrine therapy plus palbociclib versus standard monochemotherapy in women with high-risk HER2 negative, hormone receptor positive metastatic breast cancer and indication for chemotherapy. That's what about Padma study. So what does it mean? That of course in the hormone receptor positive and HER2 negative metastatic breast cancer, the standard of care as per guideline is of course the for endocrine therapy plus CDK4/6 inhibitor. But in practice, many of times physician feels that the disease burden is more, so we should give chemotherapy, and that's to challenge chemotherapy. Problem is that we have already phase 3 trial of Palomar 2 study, there is Mona Lisa 2 study, and Lunar 3 study, but they have compared endocrine therapy plus CDK4/6 inhibitor versus endocrine therapy. Here, we are comparing endocrine therapy plus palbociclib with the chemotherapy to know which is superior in this kind of patients. And it is phase 4 trial, so of course there is no doubt about that it's of efficacy. So these are the disclosures. So of course we know that that's the standard of care is ET plus CDK4/6 inhibitor, but first many of time in real world still chemotherapy is used as first line, so it is the first prospective randomized open-label multi-center phase 4 trial to compare CDK4/6 inhibitor plus CT versus standard monochemotherapy with or without endocrine maintenance as a first-line treatment in high-risk metastatic breast cancer with chemotherapy indication. Now, of course, the population of hormone receptor positive HER2 negative patients, may be male or female, there must be indication for monochemotherapy. Now, the indication is based on, of course, the European labels or based on the guideline which the clinicians are following. And of course, there should be no prior treatment for metastatic or relapsed disease. There should be no asymptomatic bone only or oligometastatic disease. So these are excluded. Of course, there should be no uncontrolled or untreated CNS mets, and life expectancy should be more than 6 months. And they are randomized to either receive endocrine therapy plus palbociclib or chemotherapy, which might be physician's choice, and later on endocrine therapy maintenance might be added. So the primary endpoint was time to treatment failure. That is defined as time from randomization to discontinuation for whatever the reason, either disease progression or treatment toxicity or patient preference or death. It can be anything. And secondary endpoint was progression-free survival, overall survival, safety and tolerability. So 130 patients were randomized, but 10 never started. So 120 patients were there, and 61 received palbociclib plus ET, and 59 patient disease with chemotherapy based drug. So discontinuation was 46%, 46 in palbociclib 80, 32 because of progressive disease. While the chemotherapy discontinuation was in 55 and 42 because of the progressive disease. So of course, if you look at the baseline characteristics, and these are of course matched, but there is you can see the sizable number of liver mass, that is 45.9% in palbociclib with ET arm and 37.3% in the chemo arm. And of course, there might be endocrine resistance of in the almost 30% patient in both arms. So there will be de novo metastatic disease in 33 to 40% of patients. Their primary neoadjuvant was allowed in 40, that was 45 to 40% patient. HER2-low disease was also taken, that is for 73.2% in palbociclib plus ET versus 58.8% in CT-based arm. And of course, there might be PIK3CA variant around 18 to 27%, BRCA2 1 and 2 in for 5 to 7%, ESR1 in 1.6. Of course, ESR1 is very less, so that's why we are talking about endocrine therapy. So, which chemotherapy, that is capecitabine, is the choice for almost 70%, paclitaxel for almost 29.3%, and vinorelbine for 1.7%. And which endocrine therapy? In the ET plus palbociclib in the 77.4%, it's aromatase inhibitor, and 22.7% it is fulvestrant. So, and of course, there might be some we have used in the maintenance in the chemotherapy arm as well. So this is the primary endpoint. This is the most important, that time to treatment failure. So that is 17.2 months with the palbociclib plus endocrine therapy versus 6.1 months with the chemotherapy arm. And if you look at the hazard ratio, there it is 0.46. So that is 54% relative risk reduction. So it's important. And if you look at these curves, then of course the curves are separating quite early. So it is not like that if you will give chemotherapy, they will act faster, and if you give the palbociclib plus endocrine therapy, then they will act slower. It's not like that. And the curves are separating quite early, and we are remaining separated for a long time. So if you look at the subgroup analysis, then of course doesn't matter whether patient is hormone resistant or sensitive, the symptom burden is asymptomatic or symptomatic, the liver mets present or not, how much is the number of mets, the de novo metastatic or later on become metastatic at later on, or what is the primary chemotherapy received prior or not, or what was the hormone receptor status. It is
in the all subgroups, the ET plus palbociclib is doing better than chemotherapy, monochemotherapy. So there is, I think it's quite clear. So there is not a particular subset where we will not like to use this therapy. And if you look at the secondary endpoint, then of course progression-free survival, then we are looking at same thing. It is 18.7 months with the palbociclib plus ET versus 7.8 months with the CT. And again, the hazard ratio is 0.45. That's almost 55% relative risk reduction. If you look at the overall survival as well, then of course in the endocrine therapy plus palbociclib, it is 46.1 months versus only 36.8 months with the chemotherapy. So of course the hazard ratio is not calculated here, but there is trend towards the better OS with the palbociclib plus endocrine therapy arm. Now, if you look at the safety signal, then of course the hematological side effects were more with the palbociclib plus endocrine therapy. There is 96.8% of all grade and 54.8% of grade 3 or 4 versus 58.6% of all grade in and 6.9% of grade 3 or 4 in the chemotherapy arm. But the non-hematological were comparable. So, of course, but you know that hematological side effects are there, but we know how to handle this. We are quite trained for them. So there was one treatment-related death was seen in palbociclib endocrine therapy, and that was related to septic shock. So to conclude, the PADMA trial in the high-risk hormone receptor positive, HER2 negative metastatic breast cancer patient met its primary endpoint and shows a statistically significant and clinically meaningful improvement in the time to treatment failure and progression-free survival for palbociclib plus endocrine therapy over monochemotherapy as a first-line therapy. So if you look at the median TTF, the hazard ratio is 0.46, median PFS, the hazard ratio is 0.45. And numerically, the trend was trend towards increased OS, that's 46.1 months versus 36.8 months. There is no new safety signal was there. So these just support the existing international guidelines. We should follow guidelines. That's that advocating the use of endocrine therapy plus CDK4/6 inhibitor as the standard first-line treatment of patients with hormone receptor positive and HER2 negative metastatic breast cancer. So, of course, guidelines are already there, but we have now the phase 4 evidence as well in favor of guidelines. So, thanks. Yes, I have mentioned this, but of course, we all know about this. So, thanks.
Thank you, Dr. Mohit. You know, we all know now we are masters of using endocrine therapy with palbociclib because that was one of the first CDK4/6 inhibitors we know, and we all have long time survivals. So that's really a nice study, and which has confirmed our confidence with this phase 4 trial. Now, I would invite Dr. Rajiv Saini, who's a senior consultant medical oncologist at SMVD Narayana Hospital at Katra, Jammu, and to talk on the destiny of trastuzumab deruxtecan versus physician's choice of chemotherapy. So that's again really interesting because this is some of the new armamentarium that we have in our basket. So over to you, Dr. Rajiv.
Thank you, sir. Thank you, sir, for the introduction and the invitation in this symposium. So straight away, I will share my screen. So as all of us know very well about TDXT, wherever this drug has been tested, it has created headlines. So earlier, it has changed our perspective in HER2 positive cases, but now it has changed. It has come into it has making its strides into hormone positive breast cancer also.
Rajiv sir, sorry to interrupt. Kindly make it as full screen.
Yeah, now it is full screen.
Done, sir.
Okay. So we all are well aware of Destiny Breast 06, where this drug TDXD has shown PFS, has achieved its primary endpoint in against physician treatment choice. Now, in this additional analysis from Destiny Breast 06 has been presented in SABCS, and we are just going through it. So, what is the study design of this trial? In this is a phase 3 randomized multicenter open label study. In this patient, hormone positive metastatic breast cancer were enrolled, who are either HER2 low, that is ISC 1+, or ISC 2+, but ISH negative, or HER2 ultra low, that is ISC 0, but with membrane staining status. And this patient where patient has not received chemotherapy in metastatic breast cancer setting. And these patient has either received 2 or more than 2 lines of endocrine therapy plus with or without targeted therapy for metastatic breast cancer, or 1 line of endocrine therapy. And those patients who has progressed within 6 months of starting first line endocrine therapy with CDK4 inhibitor, or those patients who has received 1 line of therapy and recur within 24 months of starting adjuvant endocrine therapy. So around 436 patients, more than 400 patients were randomized in 1:1 ratio randomization in each group. In treatment physician choice, 60% of patient has received capecitabine, 25% of patient has received nab-paclitaxel, and around 16% patient paclitaxel. So the baseline characteristics, I'm not going through it because it has already been discussed in primary study, but there are few important points. The median age is 58 years, and ECOG performance status is 1 in more than 42% of patients. 31% patients are de novo metastatic breast cancer, and primary endocrine resistance were present in 31% of patients. The primary endpoint, which was PFS in HER2 low patient, it is 13.2 month in TDXT group versus 8 month in TPC group. And secondary endpoints were PFS in intention to treat. That is when we add HER2 ultra low group population also in these patients. Again, it has not changed this median PFS, that it is remains same, 13.2 month in TDXT versus 8.1 month in treatment physician choice group. OS is yet not matured, but early trend showed benefit in TDXT arm. Other secondary endpoints were PFS2 and safety and tolerability. So in this analysis, they have 3 main objectives. One is to investigate the benefit of TDXT in patient with different response to endocrine therapy. So they have subdivided in this first objective, they have subdivided patient into into TTP group in 3 group, that is less than 6 month progression on first line endocrine therapy within 6 months, 6 to 12 months, or more than 12 months. And second group is primary versus secondary endocrine resistant. Second objective is to assess the efficacy of subsequent therapy post progression on TDXT, that is PFS2. Third objective is to understand the benefit of TDXT on the basis of tumor burden, whether what is the benefit in low tumor burden or high tumor burden. So coming to the first objective, as I have already told, that is they have divided TTP group in 3 subgroup, that is less than 6 months, 6 to 12 months, and more than 12 months. In less than 6 months, the benefit with TDXT is around 7.5 months. In second 6 to 12 month group, it is 6.3 month benefit, and in more than 12 months group, it is the benefit is around 4.7 months. And in second group, that is on the basis of endocrine resistant, in primary endocrine resistance, the median PFS is 12.4 months in TDXT group versus 6.6 in TPC group. And in secondary endocrine resistant also, the median PFS in TDXT group is 13.2 months versus 9.5 months in TPC group. So, excuse me. So the TDXT improved PFS versus TPC regardless of time to progression on first line endocrine therapy with CDK4 inhibitor or type of endocrine resistance. Similarly to PFS benefit, you can clearly see that TDXT improved overall response rate and duration of response in TDXT versus TPC across all TTP subgroup and in patients with primary and secondary endocrine resistance. The overall response rate is to the tune of more than 60% in all the subgroup, whether it is less than 6 months, 6 to 12 month group, or more than 12 month group. And even in primary endocrine resistant and secondary endocrine resistance, the overall response rate is near 60%, while it is only 25%, around 25 to 30% in TPC group. And the median duration of response is also more than 11 months, and in more than 12 month group, it is around 15.7 months. Similarly, in secondary endocrine resistant group, it is more than 15.4 months. So it has improved ORR and DOR in all the subgroups. Coming to the second objective, that is PFS2. PFS2 in the overall intention to treat population, the difference is 5.6 months. Median PFS2 is 20.3 months in TXD group and 14.7 months in TPC group. And similarly, if we see the time to progression subgroup also, in less than 6 months, the median PFS2 is 18.9 months in TXD group and 15.2 months in TPC group. And the benefit is also seen in 6 to 12 month group and more than 12 month group. So even after discontinuation on TDXD, the benefit remains sustained in subsequent therapy also. So coming to third objective, that is PFS by measure of disease burden. So if we see low disease burden, that is less than 3 local or metastatic sites at baseline, or more than 3 local metastatic site at baseline. In low tumor burden, the difference between the two arms is 6.9 months, while in high tumor burden, it is 4.2 months. So PFS benefit with TDXD was observed regardless of disease burden, with notable efficacy in patients with lower disease burden. Coming to the safety in time to progression and disease burden subgroup, you can clearly see that any grade adverse effects are somewhat equal in both the group. Slightly higher grade 3 adverse effect were seen in TDXD group, and serious adverse effect were somewhat equal in both the groups. However, as expected, ILD or pneumonitis related side effects are more in the TDXD group. So safety profile for TDXD and TPC in time to progression and disease burden subgroup were in line with overall safety population. So to conclude my presentation, TDXD demonstrated a clinically meaningful efficacy benefit versus treatment physician choice, regardless of TTP on first-line endocrine therapy. This included patients with rapid progression on first-line endocrine therapy. Efficacy outcome were consistent in patients with primary or secondary endocrine resistance. PFS2 also favored TDXD in all the subgroups, and it also demonstrated efficacy regardless of disease burden, with much more pronounced benefit in low disease burden, and safety profiles is also consistent with overall safety population. So TDXD is an effective treatment option in patients with hormone positive, HER2 low or ultra low metastatic breast cancer following more than one or more than one endocrine based therapy. Thank you, and back to organizers.
Thank you, Dr. Rajiv, for a very elucidate presentation on this TDXD. And we all know it has been working very well. We've all had experience with this. Now, in the interest of time, I would like to conclude the meeting and just bring out some salient points, what we've learned from this meeting. That definitely technology, as far as the imaging is concerned, which was, narrated by our radiologist, Dr. Nidhi, that we can actually find out now before the surgery who are the complete pathological responders, and obviously we can wait for some more data, followed by Dr. Vedant's presentation that we are minimizing surgeries. We are now even avoiding sentinel node biopsies in a certain group of presentation, which is definitely something interesting and something to look forward, because though he said that the disturbances in arm movement and happens in 1 to 2% of patients, but even there is a group of patients for whom these things does make a difference. Technology wise, improving in the evaluation of the disease, especially looking at the circulating tumor DNA, is definitely an in thing for us, and which has definitely improved our survivals and patients, helping them in tailor making the treatment. And newer trials coming in which says that antibody drug conjugates like Kadcyla, they show superiority over monoclonal antibodies, is definitely something which has given improved survivals to our patients. Again, going on to the molecular level and targeting these molecules with olaparib has further improved survivals in our patients who are BRCA mutated or who have a genomic factor pertaining to breast cancer. Further, since the beginning of the start of the treatment of breast cancer, if you look at the Halstedian era, we have been just minimizing the treatment and minimizing the surgeries. Initially, it was just minimizing the surgical role. Now, it is even we are looking forward to minimize the role of chemotherapy, the targeted therapy, and the endocrine therapy in certain group of patients. I was supposed to talk on HER2, dual HER2 blockade. Now, we all know that there are three ways to block HER2. That is through tyrosine kinase inhibitors, monoclonal antibodies, and ADCs. That is the adjuvant, these antibody drug conjugates which we use, and the newest we have, which was spoken by Dr. Rajiv. So, there were trials which showed improvement with the use of combination of tyrosine kinase inhibitors along with the ADCs and with chemotherapies. But definitely, we burnt our hands in lung cancer by combining tyrosine kinase inhibitors and chemotherapy. And similarly, in these trials also, the incidence of toxicity was much higher with drugs like pyrnitinib and tucatinib in combination with Herceptin and pertuzumab. So we need to look forward, whether these combinations would be effective or efficacious or no. So that only future will tell. And at the end, I would like to thank Tarun Mathurji and Roche, Intas, and Cipla and MCure for helping us to frame this event. And all of my participants and all the esteemed doctors and medical oncologists, radiologists, surgical oncologists, everyone, I thank you all for the bottom of my heart for making this event a real success. Thank you so much. And with this, I hand it over to Tarun Mathurji to wrap up the meeting.
Thank you. So thank you, sir, for this opportunity. And of course, from the bottom of my heart, I'd like to thank all the esteemed panelists, the speakers, the faculty, and of course you for putting so much of efforts. And with this, thanks to my colleagues Abhimanyu and Gitika for putting a great show. With this, we say stay blessed, stay safe, a very happy Sunday, and looking forward for many more. From all of us from the organizing team, good night and thank you so very much.
Thank you.